Dr. Mark Gilbert received his medical degree from the University of Ottawa in 2000 and his subsequent master's degree in health sciences and fellowship in community medicine from UBC. Prior to coming to work for BC-CDC in 2006, he was the medical officer specializing in communicable diseases for the Vancouver Island Health Authority. Dr. Gilbert joined the BC-CDC as a physician epidemiologist in 2007 and currently works in the Clinical Prevention Services Division, where he leads the provincial communicable disease surveillance systems for HIV, sexually transmitted infections, tuberculosis, and hepatitis C. And, if that weren't enough, he also leads the provincial point-of-care HIV testing program. His research interests include gay men's sexual health and the evaluation of online sexual health interventions. We're honored to have Dr. Gilbert. Thanks.
Okay, Thank you, Jody, for that introduction. I just want to start off by saying it's really an honor to be here. The summit is certainly one of my favorite events of the year, and coming every year is sort of one of the highlights that I look forward to. So it's a real honor to be asked to sort of give some opening remarks to kind of set the stage. I also want to really say that it feels like quite a privilege to be here, having gone through that ceremony that we all experienced, and a real commitment demonstrated by CBRC to the Truth and Reconciliation Commission. So kudos for that, and it's a real privilege to be here and part of that. So, one of the things, so just to put my background in perspective, I'm approaching sort of the idea of combination prevention from my perspective as a public health physician, as someone who works within a government health agency. I'm looking in the audience. I know many of the faces here and know that there are many people in this room who have a variety of expertise and experience related to combination prevention, and certainly my thoughts are not necessarily what other people might think, and that's part of, I think, trying to kick off some discussion around combination prevention as the theme of this year's summit. So I thought it'd be helpful just to at least establish a common playing field about combination prevention and what we're talking about. So if we're talking about combination prevention, ultimately we're talking about HIV prevention at the core of combination prevention. So this graph just shows the number of new HIV diagnoses amongst men who have sex with men in some provinces where we have sort of enough data or publicly available data to look at this. With Alberta, it's the number of male cases, which is a bit different. But just looking at this, you can see that over the past 10 years within different provinces in Canada and overall in Canada, I'd best describe our trend in new HIV diagnoses as a bit of a holding pattern. So things look kind of stable. There are some encouraging signs that things might be decreasing in some provinces. But again, the decline's not as fast as we'd probably like to see, and we know that there have been other populations that have seen more dramatic declines. And so we're really kind of in this holding pattern right now, which is why talking about combination prevention and new approaches is so timely. But it does beg the question, what is combination prevention? And for some of you are probably really familiar with this term and experienced with this concept, but for others it might be newer. So I thought it's helpful just to talk about what we mean by combination prevention, or what is one meaning of combination prevention. And so I know we're going to be hearing from Will Nutland about the experience in London and the UK. So I thought it'd be helpful to use another case study. In this case, we use the case study of New South Wales, which is the southeastern state of Australia that includes Sydney. Some of you may have seen the reports that came out in the media, on social media through AIDSmap, for example, in August of this year, based on a release of the number of new HIV diagnoses amongst in the New South Wales state, and particularly amongst men who have sex with men in 2017. What the graph shows, it shows the number of new HIV diagnoses in the state amongst men who have sex with men by quarter, so there's 4 quarters in a year. And what was really notable, and the reason for this release, is that you can see at the last 2 quarters of 2016 and the first 2 quarters of 2017, a decline in the number of new diagnoses amongst men who have sex with men. And these were to the lowest levels on record, so the lowest levels per quarter since the record keeping started in the late 1980s. So I think what's particularly remarkable about this, I mean, you might look at this and say, yes, that's a really encouraging trend, but is this just variation? Is this, are we going to see an increase? What's notable, and I think led to some of the press, was the fact that there was an attribution of this decline to a new strategy in New South Wales for HIV prevention that really had at its heart combination prevention. So using this again as sort of a bit of a case study, often now when we're talking about combination prevention, we're talking about three general areas. We're talking about, this comes straight from that New South Wales strategy, we're talking about testing, increasing access to testing for earlier diagnosis. We're talking about early initiation of treatment, so people once they're diagnosed with HIV are quickly connected into care and engaged in care, and both for their clinical benefit, their own benefit, as well as prevention for unsuppressed viral loads, as well as then prevention, so things like condoms or PrEP or PEP, or harm reduction around drug paraphernalia, and those kinds of things being sort of key components of population combination prevention, with the goal, as stated in New South Wales, of ending HIV. One of the things, and certainly in looking at the data that came out with this report, certainly there was evidence of increasing testing over this time, of increasing earlier initiation of treatment. The other striking thing that many people have commented on, or sort of attributing this to, is the increased use of PrEP in New South Wales. So this is data from that state of the number of people who were, a number of gay men or men of sex with men enrolled in a PrEP trial in that state. And you can see a steady increase to over 6,000 men. Excuse me. As part of that trial over this time period. So really, even though this is all in what we call ecological level data, we're looking at sort of comparing trends and seeing if there's a relationship, and you can't necessarily prove for sure. This is pretty conclusive, or certainly very suggestive that combination prevention and PrEP has had an impact. So if that's the basic sort of package of combination prevention, the testing, treatment, and prevention, I thought it'd be helpful to take a little bit of time and think about what does this look like in Canada for us today. And so as some of you know, although I'm not doing a lot of surveillance and epidemiology these days, I can't resist having graphs in my presentation, so apologize for that. This is data that comes from the 2014-15 Sex Now survey, looking by province at the proportion of men who reported never testing for HIV, shown in the blue wedge in each province. So we can see that while there's been there is a lot of engagement amongst gay men in testing. Generally, gay men are testing often and testing frequently, but we know that there are still pockets of places where we need attention. And certainly if we were to look at this stratified by age, we would know that this would be even more pronounced amongst younger men in terms of never having tested before. So clearly I think we're doing well when it comes to testing, but there's clearly room for improvement. In terms of, as some of you know, it's very difficult to find Canadian measures in terms of, people on treatment, engagement in care, what people call the HIV care cascade. So I chose to use this, which was recently released from the Ontario HIV Epidemiology and Surveillance Initiative, which some of you know I was really critical and part of helping develop these, so I am very biased, even though they are the best cascade estimates in Canada. What this graph shows is looking in Ontario at the proportion of people who are diagnosed with HIV, so have an HIV positive result, that are engaged in various steps of the HIV care cascade. So the blue graphs showing the number of people who are engaged in care, defined as having a viral load test done. The orange, or sort of the yellow, showing the people who are on treatment, and the red then showing the number of people who are virally suppressed. And what's clear just by looking at this graph, you can see that measures of being on treatment and viral suppression have dramatically increased over time. And we know that this is a common pattern. We've seen this in BC, we see this in other places as well, and generally speaking to people who are involved in the care of people with HIV, once people are on treatment, suppression rates are very, very high. And so I think this is a very dramatic improvement. And we also know from studies that this is looking overall at all all people in Ontario, but we know from studies that have looked at differences between different populations that gay, bisexual, and other men who have sex with men often have the highest rates of linkage to care, being on treatment, and viral suppression. So I think what that really means is that if we're thinking historically and where we are today around HIV in Canada amongst men who have sex with men, we really have to acknowledge the contribution of men who have HIV in our community in terms of really being the driving force, but keeping our diagnoses sort of stable and in check. Long before there was knowledge of the U equals U and the effective viral suppression, we know that HIV positive men have been suppressed for a very long time, and I think that's really important to acknowledge, as well as all the other behavioral measures that men take to protect their partners. So in terms of prevention and thinking about condoms, well, we know condoms have always been a mainstay and still are a mainstay of prevention campaigns and prevention messaging. And many gay men, bisexual men, do use condoms and use them regularly. We know, though, that condoms have become, the idea that a condom has to be used every time is not really the case anymore. We know that there are many forms of condomless sex, which is how we're trying to talk about sex versus unprotected sex, and being in public health, I know that's a bit of a shift, but we know that there are many forms of condomless sex or anal sex that have lower risk of HIV transmission compared to others, and these are now sort of part of the mix of prevention strategies that we have today. And finally, I think we're going to have lots of discussion about PrEP here at the summit. As Jody mentioned, it's great news to know that in Ontario and in Quebec, men are able to access PrEP, and we know that our First Nations, Two-Spirit, other Indigenous men are able to access it through insured health benefits, but there's many, many gaps in PrEP access. And so, for example, here in BC, we know that if you live close to the border, or if you have a certain type of healthcare coverage, you can access PrEP, but by no means is it readily available for the majority of men who need it. So I'd also like to just comment and talk a little bit about this concept of ending HIV, which is language that was in the New South Wales strategy, but we've all seen this language in other strategies or in other discussions around the role now with combination prevention and ending HIV. So I think this is language just to challenge a little bit, not that I'm a Debbie Downer, but I think that we need to be a little bit, think carefully about what we mean by this. Certainly we know that even if we were to tomorrow, stop on a dime new HIV infections, that people would still be living with HIV for another 50, 60, 70 years. And so currently we're not really ending HIV. We also, I think part of what I'm concerned about when I see this language is that I hear from people perhaps who aren't as sort of connected to the work or connected to the community, this concept of like, well, we've got HIV covered. We don't have to worry about HIV anymore because we have these tools and because we're on a track to get rid of it. So we shift our attention to other things. And I think that's troubling, and we need to challenge that. So mindful as well of what Rocky had said earlier about, that, when people are actually presenting for intervention, we sort of missed a window in terms of some of that prevention piece. And I think that's a really important message. We know that there are still many, many barriers to accessing combination prevention. So this is data that Jeff Morgan and Travis Salwi prepared from the CBRC, the last Sex Now survey round, looking in BC at the number of HIV negative or men who didn't know their status, and looking at how many sort of met criteria for two common indications for PrEP. A HERE score of greater than 25, that's kind of a risk score that's used to sort of triage people into PrEP or no PrEP, or having a sexually transmitted infection in the past year. And then looking within those groups at the number of men who actually didn't have access to the primary care that would be needed for PrEP, either having no primary care provider or not being out to their care provider. They haven't told their care provider that they have sex with men. And in both cases, about half of men didn't have ready access to primary care. So just having the availability of PrEP, say if it's funded provincially, isn't going to be enough. We have to be thinking about these structural barriers around appropriate access to care. We also know, certainly if I'm anywhere outside of the summit, and I mentioned the term syndemic, it requires a lot of explanation, but I know a lot of people here in this room are really aware of syndemic, and that really has been a theme through the summits over the last few years. And we know there's convincing evidence, this is a sort of in relation to HIV incidence and risk for new HIV infection, where we know that there's a clear path between sort of experiences of marginalization and adversity, including homophobia, racism, stressful life events, rejection, in relation to mental health issues, anxiety, depression, problematic substance use, in relation to sexual risk-taking and HIV. And the notion as well that protective factors, things like resilience and community supports and peer norms and really thinking about that can really help to mitigate that. And that's sort of an effort that we really need to focus on, that protection and fostering resiliency. So even though I'm not super familiar with the literature in this area, it's not really that difficult to sub HIV incidence and sexual risk and sub that in terms of outcomes related to combination prevention. That we know that these same kinds of issues affect the ability of people to access HIV care, for example, and can lead to poor HIV outcomes. So without just focusing on accessing to care or the things around care and combination prevention, without paying attention to these upstream factors, is also would not be a successful way to proceed. I also just want to acknowledge that we know that there are still many factors that act in the opposite direction. So factors that can act to sort of influence or facilitate the spread of HIV, including sexually transmitted infections like syphilis. I also use this image in particular because because of the concept of syphilis history, because I think it does provide an important case study in the sense it's a good example of public health hubris. Back in the late 1980s or early 1990s, there was a lot of hoorah about eliminating syphilis, and there was actually campaigns to eliminate syphilis in Canada and other countries. And again, we all know that syphilis is now, has certainly staged a comeback and certainly is part of what we're dealing with now. And so I think it's just a reminder that even if we are successful in achieving really low numbers of new HIV diagnoses, that we have to make sure that we're still putting those bulwarks in place and really emphasizing those protective factors so that we're not seeing a resurgence again in the future. So really, although it's not quite as pithy or as catchy, I think what we're really talking about is virtually eliminating and sustaining the elimination of new HIV diagnoses. So I don't suspect I'll need to trademark that anytime soon, but really I think that's what we're talking about. So, I mean, I'm a big believer in combination and prevention and really want to support and ramp up access to PrEP and other interventions. So I think that's really what our challenge is now, is how do we ramp these up, as well as how are we really being attentive to men who may be facing barriers to accessing these services, and really being quite deliberate and careful in that, and thinking about men who may also be at the intersection of sort of multiple barriers or multiple determinants influencing access. So just some thoughts then in terms of like what then could be in our package, what would be in our combination prevention package. So, and when I was preparing for this talk, I looked back through the medical literature, which is sort of a bit of a skewed lens, but still to look and see when were the first mentions of combination prevention in relation to HIV. And at least in that literature, it traces back to the International AIDS Conference in 2008 in Mexico City, where this was sort of really talked about at that conference in tandem with a series on HIV prevention from the Lancet, so quite prestigious. And at that time, this was one of the conceptions of what combination prevention would look like, which was sort of thinking that to really have like highly active HIV prevention, it was really looking at a combination of multiple things. It was looking at treatment and antiretroviral therapy, treatment of STIs, and this was long before we had full knowledge around the impact of viral suppression. It's also then looking at biomedical strategies like condoms, looking at behavior change, looking also then at some of those determinants, looking at social justice and human rights. And what I also really liked about this framework is that it really emphasizes the importance of community involvement and leadership in scaling up access. So drawing some inspiration from this framework as well as kind of what we know, I'd posit that we're looking at, to me, this is kind of the framework for thinking about combination prevention. It's really about, we do want to focus on those individual level strategies around testing, treatment, and prevention, but we also have to be at the same time thinking about what are the factors that are acting at a community level in gay communities in relation to that, substance use, mental health issues like that, as well as then being really attentive to the continuing need for structural and social barriers and addressing those, not the need for the barriers, and the need for interventions to challenge and change those barriers. As well as, as a fundamental part of combination prevention, as well as broadly speaking for gay men's health in general. And I do think that those original elements of community involvement and leadership are also really important elements to contain within that framing. So the idea then is just some general thoughts, my thoughts. I look forward to hearing other people's thoughts over the next few days on this theme and hearing about some of the examples of things that are going on in different parts of Canada and the world. And would turn it back over to Jody. Great, thanks.